Hi everyone, this is case for debrief. I think it's going to be very short. I didn't hear much, comments or feedback from the facilitators. A lot of them mentioned that the case was pretty straightforward, and a lot of you guys did a very good job on the case. So, good job, everyone. Again, as I'm, half done in previous debriefs, I'm going to go through some therapeutics points first to kind of clarify. So one of the points that some facilitators were asking me to kind of cover is regarding the doses for the low molecular weight heparin or the unfractionated heparin doses. So it sounds like a few students are recommending for this patient specifically the Lovenox, which is great. That's the good options for pregnant patient. But the dose might be inaccurate. So for this patient, what we want to do, right, it's to give them treatment for the DVT that she had before, right? Because she was on the rifaximin before, but now like we can't have her on the DOAC anymore because of teratogenicity risk. So now we're going to switch her from rifaximin to Lovenox or the enoxaparin. And we want to be very careful, okay, with the dose. A lot of times this is kind of like a misconception and also error that can happen in the medical setting where we are recommending the wrong dose for the patients. So again, in this patient, we are going to be treating the DVT, not preventing, because she already has the DVT. So if you look at the lexicon, you are going to see that the dose for prophylactic versus treatment is going to be different. For treatment, it's going to be obviously a higher dose. Typically, it's 1 milligrams per kilograms twice daily, or if you want to do once daily, which is available as well, it's going to be 1.5 milligrams per kilograms once daily. And this is very different from the prophylaxis or the prevention doses, right? Because the prevention is you're going to just do like 40 milligrams sub-Q daily. So again, very, very important to know what's the purpose of giving the anticoagulations or the low molecular weight heparin. And from there, you can determine what dose is appropriate for this patient. And that is for this patient, because we are treating, we need to give them the treatment doses. Similarly with unfractionated heparin, I know it's not the best option for the patients compared to the Lovenox, but if you do encounter unfractionated heparin, you need to switch them from other oral anticoagulants. For some reason, they are not indicated for it, or like if you want to treat them for DVT or PE, or any AFib, then you want to make sure you're giving the right dose. For the right indication, right? Again, prophylaxis and treatment is going to be different. For unfractionated nated heparin, you can the route there is two routes that you can give the unfractionated nated heparin. You can either give it to sub-Q or the IV, which is the IV drip heparin. So those are going to be determined in terms of your indication. So if you want to give them prophylactic doses, you're going to refer to your sub-Q route, right? Typically it's about 5,000 sub-Q, Q8 hours or Q12 hours, depending on the patient's characteristic. But if you want to treat them, again, for DVT, PE, sometimes AFib too. For AFib, it's kind of controversial. It depends on your heparin protocol in the hospital. But for sure, for DVT or PE, you want to give them the IV. Just because the sub-Q one, you can't give it as high as a dose, like too high of a dose. And you can only give it IV in terms of treatment doses and making sure they're getting the right amount of heparin to treat the DVT or PE. The second part is tetracycline use in pregnancy. So hopefully everybody kind of have that precautions when recommending this antibiotics, right? So tetracycline have been shown to cause some development problem when you're pregnant or even like children, right? So that's why you typically don't want to use it in this patients who are pregnant or children. For this patient specifically, I am okay with students recommending doxycycline, or, like for the pneumonia in this case, just because you have to know specifically what timing, like what trimester that the risk is going to happen, right? And I just want to show you guys in terms of, like where you can get those details. It's not just kind of brushing up, like the pregnancy category and lexicon, or just kind of looking through your lecture note, right? I want you to really understand why we can't use certain drugs on some patient, because sometimes, there is difficult situation like this one where, we might want to cover for the atypical microorganisms for the pneumonia, but then we don't have that much choice, right? In this case, the fluoroquinolones are definitely contraindicated because of they are pregnant, azithromycin because of the allergies, and your last one, doxycycline. If you just kind of go through your lecture note, or just kind of hear about other people saying like, oh, you shouldn't be using tetracycline for pregnancy or in children, then you might not have recommended, right? But if you look further, like in lexicon, I typically, you will go to the reproduction, pregnancy, lactation section to see what kind of risks they have in those patients. This is typically, the sections kind of talk about a little bit about the studies in terms of if it goes through placenta, or, if for breastfeeding information. But I like to click into this link, actually. Bricks resources. This is a book that you can print out, but it's also available online as well, integrated in lexicon. This gives you a good summary. So I always go in this link instead of just kind of go through the the lexicon informations. So it gives you more detailed recommendation. So in this case, the tetracycline is contraindicated, but like it's mostly contraindicated in second and third trimester. And then it kind of give you more summary in terms of why, why the recommendation was made. So in this case, typically the pregnancy summary will have like some explanation as well, but in this case, they probably have like other links or something like that. So if you look at it, like they have all the summary here. So tetracycline, like extreme caution in pregnancy, because of the risk for the fetal, and everything else, placental transfer, human data, and stuff like that. So if you look into it furthermore, you can kind of like see in terms of, why we might not have used it in second and third trimester, but, first trimester might be fine, just because the if the teratogenic effect is because of the tooth discolorization, this tooth or teeth discolorization, right? So that development typically happen in the second and third trimester, or like last half of the pregnancy. So that's why, in the first trimester, we don't really worry of it as much, although some providers still take precaution, of course, right? But that's the reason why. So I want to encourage you, every time you see recommendations, or you hear something about like, oh, you shouldn't be using it on this patient population, or like, certain patient characteristic, try to dig deeper. Why, right? What's the mechanism? So you can understand better in terms of, when to use it, when to not to use it, and then it can retain better in terms of, like your future applications for all of this knowledge. All right. So the next one, for clinical pearls, Dr. Adam Case would like me to kind of refer you guys to his paper. He wrote like an article regarding tetracycline antibiotics that can cause esophageal perforation if you take it at that time. I'll put in the link and with my the announcement for the CB4 debrief release, so that you can refer to it. But this is kind of like the article that he wrote with his colleagues in terms of the risk of the perforations if you take the tetracycline classes antibiotics at that time. So, just want clinical pearls to note for future references, to make sure educating the patients in terms of administration time for tetracycline. And lastly, there are some confusions or like some misconception regarding paroxetine, tapering versus discontinuation with the patients. So I applaud people who are thinking about the cross-reactivity or cross titration, because as you all know, for those who recommend it, right, the paroxetine or most of the SSRI, SNRI, except for the fluoxetine, they do have short half-life. So, and as you guys know, like it takes some 4 to 6 weeks, right, for the drugs to take effect in the body to make the depression symptoms or to improve the depression. So for this patient, you have to kind of think about the bigger picture as well, right? Why in the first place we want to switch the patient from paroxetine? The main thing is because of the teratogenicity risk, right? So in this case, if you think about it, right, you want to kind of weigh what is the benefit of tapering versus like just cold turkey discontinue the medication versus the risk of tapering it, right? So in this case, if you think about it, tapering the paroxetine, it helps to sort of get the other antidepressant that you're recommending to take effect, and so we can kind of like control the depressions while they're starting to work with the new antidepressant. But again, going back to the reason why we want to switch the antidepressant is because paroxetine is teratogenic, right? We don't want to use it in this patient because this patient is pregnant, right? So with that mindset, right, what is the benefit or the risk, right? The risk while you're tapering the paroxetine, they still getting the paroxetine in their system, and it can start causing fetal harm, right? So it can lead harm to the patients. I know you can further argue that, well, if we discontinue it and then the other antidepressant doesn't start working, we might worsen the depression and it can also cause harm, right? Yeah, sure, but then we can continue to monitor, right? You still have control, or like you can still recommend some monitoring, some like close-up follow-up, making sure the family members are aware of, the risk of kind of rebounding with the depressions, just because we don't want to harm the fetus, right? So again, benefit versus risk, right? In this case, I would say, it would be more beneficial for the patients to just discontinue the paroxetine without the tapering, and then we'll start the other antidepressant right away as safely as possible. Just continue monitoring frequently, monitoring closely, making sure the family member can support the patient during the transitioning period to make sure they don't have any depressive symptoms, or the depression doesn't get worsened during that time. And while at the same time, we minimize the risk of fetal harm as much as possible in that case. All right. So that's it for the debrief today. Hopefully this is a good case to kind of show you what to do, in terms of working up pregnant patients, because sometimes, it might come up, once in a while in internal medicine. And it is very important to make sure, like you have all the tools or all the resources needed to make sure that you are equipped in working up pregnant patients. Thank you. Good job. And we'll see you in about 2 weeks.